since we are running short of time, we'll be very quickly running to the next session, where we'll discuss the recent advances and updates in ECMO. For moderating this session, I would request the presence of Dr. Yatin Mehta, Dr. Suneet Kathuria, Dr. Sameer Kapoor, and Dr. Samiksha Parashar.
Our next speaker is Professor Alain, and he'll be speaking on VV ECMO key papers since 2017. He needs no introduction. He has a very beautiful trial. He was associated with EOLA trial, and he has more than 80 publications to his credit in PubMed journals. His special achievements are he's the past president of EuroESLO, and he is associate editor of Intensive Care Medicine, IF41. Dr. Alain, he'll be joining us online.
Hello, I'm Alain Combe. I'm a professor of critical care medicine here in Paris Pitié-Salpêtrière Hospital. So I have the privilege to talk to your great event, and I will discuss with you today the latest studies published over the past 6 years about VV ECMO for patients with severe ARDS. This is first my discussion slide. Of course, the first study I will discuss with you is the EOLIA study, which was published in 2018 in the New England Journal of Medicine. This study included sick patients with ARDS, and disease severity criteria were defined, and those patients with a PF below 50 for more than 3 hours, or below 80 for more than 6 hours, despite the potential recourse to nitric oxide recruitment maneuvers for positioning. There was also a criteria of severe respiratory acidosis, which was resulting from severe decrease in non-compliance and very high respiratory pressures, the PA CO2 over 60 for more than 6 hours with a pH below 7.25. Patients were randomized either to ECMO or to controlled mechanical ventilation. Those who did receive ECMO received percutaneous VV cannulation, and mechanical ventilation was decreased. The intensity was decreased, targeting a low driving pressure of less than 14 with a PEEP of 10, whether with pressure control APAV ventilation or volume assist control ventilation. And those patients randomized to control treatment received conventional 6 ml per kilo predicted body weight tidal volume with a PEEP targeted to reach a PEEP plat of 28 to 30 centimeters of water. And there was also a strong recommendation for prone positioning and paralyzing in those control patients. Control patients who did have dismal evolution with prolonged refractory hypoxemia with arterial saturation of oxygen less than 80% for more than 6 hours were a potential candidate for a rescue ECMO. They also needed a trial of prone positioning, a recruitment maneuver, and INO, nitric oxide, or inhaled prostacyclin before getting this rescue ECMO strategy. So overall, randomization included 124 ECMO patients and 125 controls. Those were quite sick patients with a SOFA score was close to 11. Very short time from intubation to ECMO, 1 day and a half in the EOLIA trial, was mostly pneumonia patients. Bacterial pneumonia accounted for around 45% of the patients, and viral for around 20% of the patient. At that time was mostly flu-induced ARDS in these patients. The PF was 72, the lowest PF in any RCTs of ARDS published so far. And as you remember, there was a trend towards less mortality for ECMO patients, 35 versus 46. The p-value was 0.07 by analysis of Kaplan-Meier curves. did not reach statistical significance, yet the p-value was over 0.05. Still, when looking at the key secondary endpoint, which was a treatment failure, these deaths in ECMO patients, or deaths or the need for rescue ECMO in control, this time was a huge difference in favor of the ECMO group, and was highly statistically significant. When looking at the key secondary endpoints of the EOLIA trial, all of these key secondary pointed for benefit of ECMO. There was less days with vasopressors, less days with cardiac failure, less days with need of dialysis, of renal failure, less need for prone positioning and nitric oxide with ECMO. Once again, all these secondary endpoints were in favor of the ECMO group. 35 controls, where 28% of those controls needed a rescue ECMO, and those patients were quite sick at the time of rescue ECMO. 9 had cardiac arrest, 6 did receive ECMO, VA ECMO for eCPR for refractory cardiac arrest, and overall 11 at renal failure requiring dialysis. And of course, the mortality of these crossover patients was much higher, 57 versus, once again, 35 for ECMO patients. And when looking only at those no crossover patients, the mortality was also numerically higher than in ECMO patients. We also had a look at subgroups, and the very interesting subgroup was the subgroup of those patients who had the lowest PF ratio, probably the sickest population of patients here. And my belief when I designed the trial was that the mortality would be clearly better for those very sick patients. And actually, it was not true. The benefit of EOLIA was mostly confined to those patients who had the PF above 66, which was the median value for that study. And as you can see here, was only 27 versus 49, highly significant difference here. We also reanalyzed the trial using a Bayesian model for statistical analysis. This was a JAMA paper published a couple of months later. And these papers concluded that the probability of ECMO saving lives in severe ARDS patients was between 88 to 99%, so very high probability of ECMO saving lives in those severe patients, as mentioned and discussed by Derek Angus in this editorial. A clinician and researcher should no longer ask, does ECMO work? Because that question appears to be answered. Yes, ECMO saves lives in severe ARDS patients. And we also did a meta-analysis of individual patient data with the CESAR trial, which was the other RCT on ECMO for ARDS, which this time showed that the mortality up to day 90 was lower in those patients who did receive ECMO. More recent data now, does prone positioning on ECMO improve the outcome of severe patients with ARDS who did receive ECMO? This is a pooled individual patient data meta-analysis we published also a couple months ago. Very sick patients here, large group of supine and prone patients, and rate of prone positioning was around 50%. Before ECMO. And when comparing those who did receive prone positioning during ECMO, there was a trend which was significant here towards a benefit from prone positioning during VV ECMO. This obviously need to be confirmed in upcoming RCTs. We have just finished here in Paris an RCT on of prone positioning patients very early after initiating VV ECMO. And of course, the last 3 years has been the story, the long story of COVID, and a lot of papers have been published about the interest of VV ECMO in COVID patients. This is the study we published about the experience here of the Greater Paris, in which we built a very efficient hub and spoke network here with advanced expert ECMO centers, including ours here in La Pitié-Salpêtrière, and also non-ECMO centers and transferring patients with mobile rescue teams. And actually 2/3 of the patients who treated during that time was here the first wave of the pandemic in the spring of 2020 were cannulated outside ECMO centers and also transport back to the ECMO centers on ambulances. Overall, the survival was close to 50% after 90 days of ECMO, and we also confirmed some prognostic factors after VVH was obviously here a major factor associated with the outcome. Also the days from intubation to ECMO, and it seems that beyond 3-4 days, the mortality is significantly higher in these patients. We also confirmed the major impact of the experience here, and specifically the number of VV cases the year before COVID was 2019. The centers who did treated more than 30 VV cases in 2019 had much better results, and also very reassuring. There was no impact of transferring patients with the mobile rescue team. Also here is a very sophisticated target trial emulation of ECMO in which we confirm the major impact of the experience of the centers on the outcome of VV ECMO patients, and was only patients treated in those experience centers for whom the benefit of ECMO was highly significant. More recent data, data from Germany here, a very large series of patients, more than 3,000 COVID-19 up to May 2021, and it was actually very surprising because in Germany is very advanced medical care here, and the mortality one of those of the highest published so far was close to 70%, and probably related to once again the low experience of most centers. Many centers were able to cannulate and treat these COVID-19 patients, and also maybe selection criteria and the age in particular was much higher in Germany at that time. ELSO published the largest experience about COVID-19. This is the second Lancet paper by the ELSO registry, showing quite good results, and especially once again for those expert centers for whom the mortality in hospital mortality is not the actual mortality was around 35%, much higher mortality over 50 for less experienced centers also in this large ELSO registry. And the latest data, it's the ECMO Surge series we recently published in the Lancet Respiratory. It's a large series of 1,345 patients treated during the different waves of the COVID up to the end of 2021. Only in large experienced centers in Europe, wild type, alpha, delta, and some other types of variants. And we first showed that the 3B waves, alpha, wild type, and delta patients had overall the same mortality. We also showed that there was a trend towards high mortality during the second semester of 2020, probably because of a bit less stringent criteria for ECMO at that time. But the survival rate went back to the expected number in the year 2021. Once again, on that series of patients, we showed the major impact of age on the outcome, and also the time from ICU admission here to intubation, probably the time on the high flow and non-invasive mechanical ventilation had a major impact also on the outcome of these patients. And last information from that study, after adjusting for all confounders here, is all the factors associated with mortality. Delta variant, patients had a higher mortality after adjusting for confounders on that large series of patients. So, in conclusions, after all these evidence accumulated in the last 6 years, first, ECMO does not kill people. Actually, ECMO saves lives to many of these severe ARDS patients. Probably possible to say ECMO not yet. I do believe that except those patients dying of refractory hypoxemia, there may be room for a trial of room positioning. And it's also possible to say no to ECMO if it seems to be futile because advanced age, severe comorbidities, the number of organs failing, also duration of mechanical ventilation at the time of the decision. And last, it's very important to build networks to make the decision, to optimize treatment, to retrieve patients on ECMO, because once again, the outcome of those VV ECMO patients is highly influenced by the experience of centers taking care of these patients. And we need now to evaluate strategies under VV ECMO. Do we need to prone ECMO patients? What is the optimal mechanical ventilation strategies under ECMO? Those are the matter of upcoming trials and studies in the coming years. And with that, I would like to thank you again for listening and to also invite you to Paris to our events next June, our Congress, and also our ECMO diplomats. Thank you again so much for listening me today. Bye-bye.
This was Alan presenting virtually on VV ECMO. Next, there's some change in the schedule, and now we'll be having Dr. Rajesh Pandey as next speaker. He will be speaking on addition of endotoxin removing filters. Can it improve outcome in distributive shock in ECMO? Dr. Rajesh Pandey, Super Specialty Hospital, New Delhi.
Thank you very much. Ladies and gentlemen, I'm the surrogate speaker for Dr. Deepal Govil, who for personal reasons could not make it. It's a very exciting looking topic. Can addition of endotoxin removing filter improve outcome in distributive shock in patients on ECMO? So let me start with, when you have a patient on ECMO and the patient goes into distributive shock, possibly will manifest as, decreasing oxygenation, rising lactate, rising base excess, dropping pH, decreased venous return and chatter and more fluid requirements. And patient is also warm and the leukocytosis and all those septic features are there. And you think that my patient has gone into, for whatever reason, into vasodilatory septic shock. So the usual options that we see are listed here. So this is what we generally do. So now, is there something more that can be done? Can we incorporate an endotoxin filter here? Now, please understand the blood circuit contact, all of us know, activates the complement system and surface activation. C3A, C5A come into the picture. Eventually, there are, activation of the cytokines, and there is a whole lot of inflammatory cascade is initiated. Endotoxins are released by gram-negative bacteria, generally in the setting of the septic shock, but eventually they also cause significant inflammation, and the inflammatory markers are released. So logically, it seems that if we can remove these, possibly the patient should improve. So endotoxin is a key component of gram-negative bacteria, and it can be measured by the diagnostic tools that are available. And we know that studies have shown that patients with high endotoxin activity assay levels have a higher mortality in the ICU. We also know that in patients who have a new organ dysfunction, the endotoxin activity assay levels rise and they are elevated than before. And this was a study which showed us that, all these patients who are having a high Apache, who are in shock, who have a deteriorating PF ratio, etc., there the endotoxin activity assay was found to be high. So there is a correlation there. Now, does it really help? That is the big question. So I will just quickly go through whatever literature we have, and this is for non-ECMO patients. There is some data available, but that is only people have looked at the endotoxin activity assay levels in patients undergoing ECMO, VV as well as VA, and they found that in VA ECMO patients, if the levels were more than 0.6, that means they were elevated, then there was a higher mortality in these patients. There was an association. So the first trial, this was Dina Cruz from Italy came to Agra in our ISCCM meeting where she presented this data. This was an Italian multi-center trial, and number was small, but these were septic shock patients who underwent exploratory laparotomy for intra-abdominal infection. And you can see the primary endpoint and secondary endpoint. Primary endpoint just looked at the improvement in MAP and decrease in the vasopressor requirement, but a whole lot of secondary endpoints were there. And what she essentially showed is that there was improvement in cardiovascular SOFA there, and the improvement in the inotropy score and the vasopressor dependency score. And in other SOFA, there was less change. Total SOFA also she showed that it is better. And finally, you can see the primary endpoint in terms of the reduction in the vasopressor requirement and improvement in MAP. There was a significant change, and this was the survival data that she showed. But because the numbers were very small, it needed larger studies to be done, but it showed an exciting pathway to septic patients beyond conventional therapy. So these were the limitations because blinding was not possible here. You were using the filters. So this was another study which looked at early initiation. So early means within 6 hours and late means beyond 6 hours. And what they found was that there was significantly more ventilator-free days and earlier weaning from the vasopressors and other drugs. So early initiation was better. As we know, in sepsis, any therapy should be initiated early. Now, this was by Didier Payen from France, and he looked at polymyxin B hemoperfusion again in septic shock due to peritonitis. This was again a French multicenter randomized study, and they had 243 patients with surgical sepsis within 12 hours after emergency surgery, septic shock for peritonitis related to organ perforation. So here in the study group, besides conventional therapy, they gave 2 sessions of polymyxin hemoperfusion therapy, and that is endotoxin removal filter as we know it. And they looked at primary outcome at day 20 and secondary outcome was day 90, and then the reduction in the SOFA scores. So this was the study design. As you can see, within 12 hours maximum the patients were randomized, and then either conventional sepsis treatment or 2 filters in addition to conventional treatment. And surprisingly, they showed that the mortality was a bit higher in the group where they had used the endotoxin filter. And although the study was underpowered, but Didier Payen pleaded that we should not be using this filter. But if you look at the study critically, there was 20% reduction in mortality. That is what he started with as an aim, was very, very optimistic. You never see 20% reduction in mortality. And there was high incidence of incomplete treatment. 38% of the study arm did not receive the second filter. So it did not fulfill the study criteria. And the endotoxin activity assay levels were not measured. So we do not know what was the impact, what was the level before or after the filter was used. Then the last study which came up recently was the Euphrates trial, because so far if you looked at the surviving sepsis guidelines, they remained quiet about the use of endotoxin filters and cytokine filters because they said that still studies are being done. So this was a good trial in the sense that it was designed very well. So they looked at septic shock patients of any origin. and they measured the endotoxin activity assay levels, and they found that if the endotoxin activity level were more than 0.6, that meant they were elevated. These patients were selected and divided into conventional treatment arm, where all sepsis management was done, and in the treatment arm or the study group, where in addition this endotoxin filter was applied. And the logic was quite simple. The methodology was standardized. All other treatment was standardized. And they also applied a sham dialysis catheter here, which was covered with the dressing, so that people who were coming to know the findings could not see whether this was a patient who was given filter or not given filter. So all patients had this there. Now, these were the baseline characteristics, which were quite similar. And then if you look at, they were looking at 5% mortality difference. Unfortunately, they could not find 5% mortality difference, and they found that the use of this in septic shock patients with elevated endotoxin activity assay levels did not reduce mortality at 28 days. So there was a lot of disappointment, because technically it should have worked very well. So they decided to relook at the data, and they did a post hoc analysis where they looked at these patients again, and they found, because initially when endotoxin activity assay was being done, the levels between 0.6 and 0.9 were said to be high, representing endotoxemia. Here in the study, Euphrates study, they had a lot of measurements where it went beyond 1 and very high values of endotoxin activity assay. So in this post hoc analysis, when they segregated into two groups where endotoxin activity assay level was between 0.6 and 0.9, and when it was beyond 0.9, they found that in the 0.6 to 0.89 group, there was a significant reduction in mortality compared to the conventional treatment with a sham dialysis catheter. So, this is apparent here. So what they said is the measurable responses in patients with septic shock and endotoxin activity assay levels between 0.6 to 0.9 on changes in mean arterial pressure, ventilator-free days, and mortality, they are good, because possibly what they concluded was the test is not sensitive, endotoxin activity assay level is not sensitive beyond say 0.9. So it is difficult to comment on higher values. But I presented to you all the data that we have. So using these in terms of the other, because it's largely, if there is no sepsis, the topic specifically was endotoxemia, the vasodilatory shock. Otherwise, the other therapy that we have is cytokine filters, because in the process, when you put somebody on ECMO, there is a lot of inflammatory response and the inflammatory cascade, and you have high levels of cytokines, which can also play havoc. So cytokine filters have also been suggested as a tool to reduce the cytokine burden and to reduce the inflammatory response. Having said that, the endotoxin therapy, filter therapy, has been is not recommended anymore based on the Euphrates negative trial. But I feel maybe they need to relook at the endotoxin activity assay itself, come up with certain values which are reliable, and they should be. We should know that if 0.6 to 0.9 is to be taken, then what do we do with values above 0.9? So that is a question that remains. Since this was given as a topic to Deepak, so I have tried to put in as much as I could. I have no experience of using this in my ECMO patients. I have used extensively all kind of filters in non-ECMO patients with mixed results. I cannot say that I can vouch whether they really are helpful. But one thing that you see immediately, anybody can observe, is that there is a drastic improvement in MAP, and there is a drastic reduction in the vasopressor dosing. Whether that translates into mortality reduction, I'm not sure. So the jury is open. Thank you very much.
Thank you, Dr. Rajesh Pandey. Thank you for sharing your knowledge. We'll take up the questions at the end of the session. So, moving forward, we have a very interesting talk on the topic lessons learned during COVID-19 ECMO, applicability to future pandemics. And for this, we have Dr. Ahmed Rabi with us. He will be joining us online with us. And over to you, Dr. Rabi.
Two trials we have discussed. Both the trials, the first negative results and positive. Probably it's more of rescue statistics manipulations. But whenever we have this endpoint, even if we are running a game or a sports, if someone is going towards it, may not reach the end. So the way you said, the personally also. So what are the money that we have also seen the patient we have used the cytokines, whether it's one or the other companies with the different parameters, like some other less surface area, some more surface area. What should be the time to put on these patients to use it exactly? Because one thing is the results are different, even the guidelines are different. But you have also seen, we have also seen some of the patients we have rescued. So, but just for the discussion, what should be the point where we should switch over to think of putting these patients in septic and in non-septic patients, although indications?
Very good question. We should use it early on, as the studies have shown that there is a faster reversal of hypotension and there is a faster reduction in the vasopressor requirement. So any therapy, if we are delaying it and using, these are not rescue therapies. Let me be very, very clear, because by that time it's already very, very late. So they should be used early. Now, how early? People have said 6 hours, 8 hours. In fact, Dr. Yatin Mehta has created a scoring system for cytokine, which can be done. And if you find the score, matching with the requirement that yes, we have to go ahead with the cytokine filter, that can be a rough guide. The dilemma that comes, Dr. Gautam, is if you are using it early, then you are always confused whether my patient would have improved without this also, or is it the magic that this endotoxin filter is playing? So that dilemma will always remain. In science, the RCTs will have to prove it, whether our good friend Ranjit Chatterjee agrees or not. It's still, the RCT era. So, but whatever therapy we are using, we should use it early on. And my suggestion is measure the cytokine levels or endotoxin activity assay levels. Use it only when these levels are high and patient is not improving with the conventional sepsis strategies. So we should use them early on. And with the benefit, we should also see the reduction in these levels. So that is important.
To connect with Dr. Ahmed, if the audience has one or two more questions, you can please carry with the questions as a session.
Now let me entertain the audience. Dr. Vinod, your experience with the toremixin and the cytokine, cytosorb and other filters that are available.
Whether some patient has improved, some patient, in spite of that, there's no improvement. So, and the RCT also does not take you to anywhere what to do in such type of patient. Regarding the, what I want to make a comment that if you want to use endotoxin level or a cytokine level, the problem is that if you are sending sample today, the result might take 2 to 3 days. That's why most of the people goes on the clinical criteria rather than using the endotoxins.
No, if you're using it, it should be available in-house so that you have an early...
Even in a house, it takes 24 hours. They will send you result in Gangaram. If you're using, they are very fast and they will give you the result in 6 to 12 hours. But still, this is the time where you have to think that whether to use cytokine or the story type of thing or not. But yes, as you told that everything cannot be measured by measuring the mortality. One thing happens that those patients who are responded, they will get a very good improvement in the MAP and the perfusion and the cardiovascular status. That's what we have said. But whether it is going to translate into the mortality benefit or not, it is still
logically
not
yes.
Sure.
Logically yes, but the statistics has to prove.
Yes, statistics has to prove it. So. Thank you.
Regarding your other question, non-infectious, now there are a plethora of
Exactly, the patients who have a lot of stress. Actually, but I'm looking at is couple of patients have survived also. Like in COVID patients also, we were difficult to use the Tocilizumab or the things we thought of using these filters in those patients. But I have seen a couple of patients where the SARS is too high, patient is having peripheral like hyperperfusions. Whether we use any sort of resorption, whether Xeris or cytosol, or even use the CRT, which also takes away the cytokines, it helps a lot in those patients. Because you get a window where the other things can act. So it's not exactly the data has come. Because if you see the person's journey who started with these cytosol services, the benefit is there, but it's not amounting because we are using in desperate situations most times. Like even pancreatitis patients, the people are using other things also. There's a lot of surgery, there are a lot of cytokines there.